It's really about the factors influencing the decisions of cataract surgery and premium IOLs in post-keratoplasty corneas, which are different than the ones in virgin cornea. We had this referred at our center, 56 years old female with a complaint of gradual visual loss and a history of penetrating keratoplasty post-herpetic eye disease. Examination showed cataract with clear corneal graft. Let's go through the factors to determine what to do with this patient and with post-keratoplasty cataract patients in general. If you plan to do cataract and IOL in post-keratoplasty, then you need to look at the endothelial cell density, a risk of disease recurrence, and graft survival. Because for your information, endothelial cell loss is 50% in PK at 5 years and 4 to 22% in DLK at 5 years, depending on the technique. Keratoconic eyes in post-keratoplasty show continuous astigmatic changes and recurrence at the third decade in 11% of the cases. Corneal graft host junction heals by 1 year post-PK. However, this may vary depending on patient's age, general health status, and the use of immunosuppressive agents. How do we reach refractive stability? It is by removing sutures at 1 year post-PK and confirming stable refraction on 3 successive visits with 2 to 3 months in between. A quick word about post-keratoplasty, cataract, and astigmatism. In post-keratoplasty, 1 in 4 patients has cataract. In post-keratoplasty, the astigmatism average is between 4 to 6 diopters. In post-cataract surgery with virgin corneas, 1 in 4 has astigmatism 1.25 diopters or more. If you add all these together, then you conclude that dealing with astigmatism is as important as dealing with cataract and post-keratoplasty. Can we use toric IOLs in post-keratoplasty? Toric IOLs eliminate regular cornea astigmatism. However, it is contraindicated in eyes with plans for RGP contact lenses and regrafting, and in eyes with potential capsular instability and moderate to high irregular astigmatism. How do we calculate the biometry? How do we obtain the lens power in post-keratoplasty? We can obtain the K value using the Holiday Report EKR 65 from the Pentacam machine and the axial length from the optical biometer. We enter all the values to the Barrett Universal 2 formula. And remember, if you're planning for endothelial keratoplasty, you should consider a myopic shift because there's the hyperopic shift in both DZEC and DMAC. Now, is marking the axis different in post-keratoplasty? No, it's just the same like in any other eye. And the source of errors are the same. However, we can always make our life easier by using the new devices integrated into the surgical microscopes. Any relation between IOL material and rotation? Yes, indeed. The hydrophobic acrylic IOL tend to rotate the least. The hydrophilic rotates more, the PMMA rotates even more, and the silicone much further. Remember that the higher the cylinder power, the higher the rotation. We choose spheric or aspheric IOL depending on the amount of total spherical aberration. And if you're planning for endothelial keratoplasty and air injection in the anterior chamber, we mustn't use hydrophilic acrylic IOL because it interacts with the air bubble and gets opacified. Phakic incision should be posterior to avoid the graft-host junction and to produce as minimal astigmatism as possible. The size should be 2.2 for the same reason. We should protect the endothelium by means of injecting dispersive OPD as part of the soft shell technique described by Akino, who used dispersive and cohesive OPD. During surgery, we should lower the infusion bottle, use mechanical forces, high vacuum, and perform phaco as far as safely possible from the endothelium. If we're not sure that the capsule or the zonule are intact, then we should remove the capsule and use scleral fixated IOL. Do we use sutures at the end? Yes, for the main incision. Even for the side port, if it leaks, and we remove the suture at 1 month post-op. The management for misalignment in post-keratoplasty is the same as in any other eye. Is there a role for presbyopia correcting IOLs in post-keratoplasty? It is contraindicated in PK and DLK because PK and DLK grafts induce significant anterior and posterior high order aberration. And it is contraindicated in DZEC as well because DZEC grafts induce significant high order aberration and reduce contrast sensitivity. DMEC grafts induce less posterior high order aberration, and there are ongoing studies on uneventful DMEC with presbyopia correcting IOLs. What about the follow-up? After the cataract, we should increase the steroid frequency to reduce the risk of rejection and do close follow-up. We used to do triple procedure for patients with cataract and corneal pathology. We do the cataract, IOL, and the corneal transplantation at the same time. But now we do the keratoplasty, and then we remove the sutures, achieve refractive stability, and then we do the biometry. We think that it is more accurate prediction of IOL power this way. This is my algorithm for the IOLs in post-keratoplasty. Well, thank you very much.